Dear friends, good evening. I am Dr. Chandrasekhar Meshram, Co-opted Trustee of World Federation of Neurology and Chief Coordinator of the Public Education Activities of Indian Academy of Neurology. I welcome you all on behalf of World Federation of Neurology and Indian Academy of Neurology for this sixth session. And this session is of great day-to-day concern. And this session is on backache, neck pain, bladder, bowel, and sexual dysfunction. And we are having this session during the World Brain Week to celebrate and make people aware about neurological problems and to maintain your brain health. I welcome Dr. Nirmal Surya. He is President of Indian Academy of Neurology and Consultant Neurologist at Bombay Hospital, Mumbai. And I have a great pleasure in welcoming invited guest faculty, Professor Ellen Merritt Hagen. She is a consultant neurologist at Autonomic Unit, National Hospital for Neurology and Neurosurgery, Queen Square, London. She is clinical director for digital healthcare at Queen Square, London. And she is a treasurer of International Spinal Cord Society. She is member of Asia Autonomic Standards Committee. She has a lot of publications. So welcome, Professor Ellen. This session will be moderated by Dr. Abhishek Srivastav, who is Director and Neuro Rehab Specialist at a Center for Rehabilitation at Kokilaben Ambani Hospital, Mumbai. And he's a convener of Neuro Rehab subsection of Indian Academy of Neurology. I also welcome Professor Manmohan Mendiratta, who is Director and Senior Consultant, Department of Neurology, B.L. Kapoor Hospital, New Delhi, and Chairman of Neuro Rehab subsection of Indian Academy of Neurology. Dr. Suresh Shankla is Head Department of Neurosurgery at Global Hospital, Mumbai. Dr. Soumya Darshan Nayak, Associate Professor and Head of the Department of MKCG Medical College, Cuttack, and Dr. Navita Vyas, who is pain specialist at Kokilaben Ambani Hospital, Mumbai. Welcome all the panelists. Tomorrow we will have a last session of the series, and it will be on loss of memory. The session will be moderated by Dr. Atanu Vishwas from Kolkata. We will have international faculty, Riyad Gouder from Tunisia, who is trustee of WFN, and Dr. Agustina Charve-Feli from Ghana. She is the president of African Academy of Neurology. And we'll have national faculty, Dr. Amitabh Ghosh, Dr. Fahim Arshad, Dr. Meera Chandra, Dr. Sujata Das, and Mrs. Vidya Sherai. So look out for the interesting session tomorrow. Now I request Dr. Nirmal Surya for the welcome address. Dr. Nirmal Surya.
Yeah. Thank you, Dr. Chandrasekhar Meshram. It is indeed a pleasure to be here. Today is the 6th day of World Brain Week, and you have been working with the team tirelessly to get the program which we promised to the World Federation of Neurology to have 100 program in a week. And we really are indeed grateful to all the members across the country to come out in a large number and doing almost 300 program. I must say that the runner team is running. They want to run the 2 million steps. The musical team is going to be there. And I think tomorrow they are going to, during the last day of the program, they might present their song for the neurologists, a effort by the Neuregama group of the Indian Academy of Neurology. Not to forget that each and every subsection, and particularly Neuro Rehab subsection, has been very active. They have done the 3 webinars. I had a pleasure to attend one of the webinars today from 4 to 5:30. So I've been practically attending all the webinars. So that's wonderful of many of the Neuro Rehab subsection. Today's program is very, very special because if you see today, we have a multidisciplinary team. You have a pain specialist, you have a neurologist, you have neurosurgeon, and you have a rehab specialist, and we all are there. And we are really talking on a problem which is universal. I don't think ever on this platform, under the banner of neurology, we have ever talked about back pain, neck pain, bladder bowel, and sexual dysfunction together. And today, during this World Brain Week, we have brought this special session because this nobody in this world can say who is working in the office that I don't have a back pain or neck pain. And of course, those who have a spinal cord injury or traumatic brain injury or some tumor has been operated, they have bladder, bowel, and sexual dysfunction, and also can be there in every elderly gentleman and those with have stroke or any other problems. And therefore, today is a special program, and I'm sure you all are going to enjoy the discussion and presentation from these experts who are there. Not only that, what is good is all these programs of the Brain Week, which has been about more than 30 programs, they are available on YouTube of Indian Academy of Neurology and Facebook. So I will suggest all of you to subscribe the YouTube or become the part of our social media, so that not only for today, tomorrow, but even in the future, on all the day of occasion of important disorders, we will be live and you could take benefit of awareness on the neurological disorder. With that, I welcome you all, especially the international speaker, my colleague Alan from UK, and she has been a wonderful lady working on the autonomic neuropathy, autonomic nervous system disorder, and I'm sure her talk is going to enlighten us along with the pain specialist Naveta and the neurosurgeon Suresh Sakla. So welcome you all. Thank you very much for being there, and please support and log on to our social media so that we can reach out to you on all the occasion. Thank you. Namaste.
Thank you, Dr. Nirmal Surya. Now I request Professor Ellen to give her talk and start the introduction to the topic, and we will take them further. So Professor Ellen, and after her talk, then Dr. Abhishek Srivastav to take over and carry on the panel discussion and question and answer session.
Okay, thank you.
Thank you very much for the kind invitation, and I'm hugely impressed by what you have achieved this week and will achieve. I seem to have some struggle to display it as a presentation. Are you seeing it as a presentation now?
Yes.
Yeah, excellent. Thank you. Yes, so I've been asked to give something on the autonomic nervous system, because we know that the autonomic nervous system affects all parts of the body. It's the housekeeping part of the body. And when something goes wrong, there's a lot of things that can be affected: sleep, respiration, digestion, bowel, bladder, sexual function, sweating, blood pressure, and heart rate. We know that we have intermittent dysfunction like orthostatic intolerance and syncope, and then we have more chronic failure in spinal cord injury, which has been where I've been working, brain injury, Parkinson, MS. So it's both the intermittent and the chronic patients. I will talk about cardiovascular dysfunction because that can lead to fall and you get both neck and back pain, gastrointestinal and urogenital function. So orthostatic hypotension is a fall in blood pressure, systolic of more than 20 millimeter mercury and or diastolic of more than 10 millimeter mercury on standing or head up tilt for 3 minutes. We can see that the blood pooling, the blood changes, and that leads to a fall. We have the postural hypotension, but we can also have a postprandial after food and also related to exercise. We measure this by having a standing test or a tilt table test. When we don't have an autonomic dysfunction, we will be able to keep the blood pressure and heart rate stable during head up tilt, while for a patient with autonomic failure, there is a severe blood pressure drop, which recovers when we tilt the patient down. And you can see that the heart rate remains stable, so there's no response in the heart rate. The patients are complaining about dizziness, visual disturbance, they lose consciousness, they feel they can't function, they have muscle ache, especially in the neck and shoulders, which we call coat hanger pain, low urine output, weak, fatigued, and it leads to falls, and may lead to falls. Triggers are changing position, standing still for a prolonged time, raising arms above the head, dehydration, meals, hot temperature. I know that it's very hot in India now, so clearly there are some challenges you are facing. Infection is another cause for orthostatic hypotension, and then pain and anxiety. We recommend that people avoid changing position very quickly, especially in the morning, avoid prolonged bed rest, high temperature, which is difficult and will be increasingly difficult in this world, large meals, alcohol, and excessive exercises. So marathon might not be a good one. And think about which drugs they are on, which may contribute. We recommend high salt intake for those who are not hypertensive, frequent supply of water, small frequent meal, maybe put the head up a bit, extra pillows at night. Counter maneuvers are good, and sensible regular exercise. You can also use elastic stockings and abdominal binders. Here are physical counter maneuvers to increase orthostatic tolerance, which has been shown to increase your blood pressure. Syncope leading to faints, faints leading to a fall. Typical standing still, heat, dehydration, food, alcohol, and exertion can all lead to this. Here you have a blood pressure drop. The heart rate tries to compensate, can't keep it, and the patient faints. Here it's the heart rate going down, blood pressure can't do anything with this, and the patient faints. Sometimes there is a bit of both. Here you can see that a venipuncture, having bloods taken, triggered a faint, and both the blood pressure and heart rate went down. We do have some situational occurrence, like during bowel and bladder opening, coughing, swallowing, and syncope during intercourse, which is something you have to ask specifically about. This is not something the patient reveal easily. Bowel causes discomfort and embarrassment. When you lose sensation of the need to open your bowels, or you lose the ability to prevent leakage, so you are incontinent, or you lose the control of your sphincter, that is a big issue and is part of the autonomic nervous system. Similarly, and what it leads to is constipation, fecal incontinence, and people are spending a lot of time on the toilet to avoid incontinence. Also, bladder incontinence has a significant impact on quality of life. You might not be aware that you need to empty your bladder, or the bladder leaks, or you struggle to empty your bladder. And lastly, having sexual dysfunction, not being able to have an erection or lubrication in women, not being able to ejaculate or getting an orgasm, sensation of menstruation in females. All these are things that is under the autonomic nervous system, and you need to ask specifically about it, and you need to ask it with care, because these are symptoms that people are struggling with. Awareness of this, treatment of as much as possible via non-pharmacological measurements, and of course we do have pharmacological measurements when needed. Education and prevention is the main thing. And with that, I thank you for inviting me.
Thank you, Professor Ellen, for a very brilliant, concise introduction on the autonomic nervous system. So the flow program will be, we'll first take about questions on the neck and back pain. Then we'll discuss about bladder dysfunction, then bowel dysfunction, then the sexual dysfunction. As you all know, neck pain and back pain are the single most common reasons for loss of absenteeism from work. People have chronic disability because of nagging issues. They don't go to work, causes loss of wages, more burden on the society. It looks very simple, but can be very complicated to diagnose and treat. Luckily, we have multidisciplinary panel today, and we hope be able to answer your questions in a much more simpler way. So let's start with the surgeon first. Dr. Sakla, what are the most common symptoms patients present to you with neck and back pain, and what questions normally we should ask to find out what is the reason for that pain?
Right. Thank you, Dr. Srivastava, for inviting me to this webinar, first of all. The neck pain and back pains are very, very common symptoms, and we see these patients on a very regular basis. As far as your question is concerned, I think, most likely the back pain or the neck pain can be diffuse or can be localized or can be a radiating types. So all these three types of neck pains or back pain should be really evaluated differently and should be treated differently and have the outcome also very, very differently. So when you see the patient in our clinics, we try and define the type of the pain the person is complaining of, like which area is involved and whether it is just localized or diffuse, or whether it is associated with some radiating pain, or it is associated with extra other symptoms like numbness or any kind of paresthesia or weakness, which the patient might not have noticed so far. So once you do that, and then the next question is to watch what actually aggravates that kind of patient, this kind of pain, whether it is some activity or particular activity related pain and paresthesia, or it is just diffuse and constant and dull aching pain, or whether the pain is present even at rest. And all of these characteristics of pain are very, very important to know before we start or before you consider any kind of therapy.
Thank you, Dr. Sakla. Let's take a neurologist perspective, Professor Mendiratha. So this patient has come to us, we know the symptoms. What are the common diseases or problems or diagnosis which can cause such type of pain?
Thank you so much, Abhishek. I'm a clinician, and I always say we have to listen to the patient, talk to the patient, discuss with the patient. Detailed clinical history is of utmost importance. There is no shortcut for that. Many times people come, sir, I have got cervical and I've got few MRIs done, just see the MRI. I said, MRI is not going to take a tablet or capsule. In that situation, we have to definitely treat your underlying cause and give symptomatic treatment. Now, causes can be from skin, right from skin to the muscles, to the bones, to the ligaments, intervertebral disc, and then come meninges, or the other bony deformity like CV junction anomaly. Those are difficult things. But what I usually say, the commonest cause of backache, whether upper or lower or middle, is postural these days. Posture. Because of long hours of working in the office, including we medicos, I often get neck pain, or if your posture is not good at night, your pillow is not good, and you have odd posture of putting 2-3 pillows under the head. So I will first put as, rather than spondylotic pain, first is the commonest occupational hazard postural pain. That is neck pain, back pain, or even dorsal pain, number one. Next comes, people often believe cervical. But again, we have to ask, as Dr. Sankla said, pain since how long? Longer the pain, likely to be benign. And if it is acute onset, which can be a catch in the back or neck, which is like a spasm. If it's a pain which is in the neck as well as radiating, then it is likely to be because of disc, most likely. But you have also to take into consideration age of the patient. Age of the patient, occurrence, acute, sudden onset, or it is chronic, progressive. Now, in addition to that, we should not forget neighborhood areas. Now, neck pain can also occur because of ear problems. Neck pain can also occur if there is something throat pain and there are lymph node neck, like jugulo-omohyoid or jugulo-digastric. Person may feel some pain in the neck, which is in the anterior part. We have to ask where. As we say in third year, which is some clinical method. Since when, where, what, how severe, tender or not. So from that, by and large, we can make the diagnosis. Other painful condition which is uncommon is movement disorder. Many people who have a torticollis or deviation of the neck may complain of neck pain, which may be quite severe, and they have been swallowing painkillers, tramadol or Ultracet for a long time, and they may have medicine overuse. So when patient comes to me, and I always say in the carry home message or what Professor Allen said, a few black films or bag full of MRIs invariably will not be in a position to solve the issue of backache. These may be complementary to your clinical diagnosis. Clinical diagnosis is of utmost importance. If somebody is a fever, headache, neck pain, obviously I will suspect meningitis. So all these should be kept in mind, but still I will say postural headache leads the list, and then these people who have migraine can have allodynia in the form of neck pain, shoulder pain. So these are common causes. I will not go further detail because other faculty members are waiting. Thank you so much.
Thank you, Professor Mendrita. Dr. Navita, in your practice as a pain physician, when patients are referred to you with a neck pain or a back pain diagnosis, how many % of patients have pain in the muscle versus those who have pain in the spine per se?
Yeah, thank you so much for this question. It's mostly, as Dr. Mendrita said, that it is the postural pain. And with this COVID and work from home scenario, it's mostly the muscle pain. 80%, 80 to 85% is the muscle pain. And 15%, we can say we can divide it into like 12% is because I see cancer patient also. So I won't be taking that into consideration, but only if we are talking of degenerative and reticular and muscle. So then 85% is muscular, or we can say chronic non-specific neck pain or back pain. Rest can be due to other causes, as Dr. Mendrita has suggested.
So Dr. Sakla, this patient has come, we know it's muscle versus the joint or the spine. So what are the common investigations you will ask for in this patient in the first consult?
Okay, that depends on what kind of clinical presentation the patient has come with. I have a full spectrum of the investigation, right from the X-ray, just the plain X-ray, to an MRI scan, and depending on the patient's condition and patient's clinical symptomatology, I would choose the appropriate investigation. For example, a patient comes with some kind of trauma and trauma-induced pain and all that, I will go for X-ray skull. And then similarly, if I suspect radiating sharp shooting pain in the distribution of a particular nerve root, I would go for an MRI scan straightway. So it is just the clinical judgment based decision of which investigation to be chosen.
Okay, so we have two categories of pain. One is primarily a muscle or a degenerative pain causing in the muscle or the facet. Second is a radicular type of pain coming from a disc. Two basic type of pain we can say. So Dr. Nayak, what is the first line of conservative management you will suggest to a patient who has a muscle or a non-specific type of pain, or a person who has a radicular type of pain?
Thank you, sir. Thank you for inviting me on this platform. And the first things we would actually ask a patient who is complaining of back pain, especially neck or lower back pain, is his workplace ergonomics, especially how he sits in his workplace, what is his workplace environment. Lot of times we see software professionals, students, people who are working from home, especially in this COVID era, they present to you with a defective posture, as Dr. Mandirath has reiterated, and especially when your workplace has shifted home. So that makes actually work difficult because of defective posturing. So, when we are asked to go for conservative management, it is our first work to take a proper history regarding his sitting posture and how and what duration of work he or she is doing. So, starting for the neck issues, the neck pain, usually the defective posture is due to long hours of sitting at one in one posture, and especially in the current era with a lot of social media activity going on, we look at the mobile at a very acute angle of the neck. So this causes strain on the neck muscles, and later on degenerative changes, as already discussed, occurs in the spine. So to correct all these things, we need to have the person sitting in a proper posture. So for a proper posture, his place of sitting, the height of the laptop or the computer, especially if the people are working on laptops or computers, should be proper. The inclination should be proper so that the screen is at the level of the eye, and the chair on which he's sitting is to be proper, especially the posture on the chair should be proper. An adjustable chair is very much important. The third point is because people sit for long hours in one posture, it is important that they are asked to take breaks. Usually, we follow the 20-20-20 rule, where a person sits 20 minutes on the chair. He's asked to look at a distance of 20 meters for 20 seconds to give rest to the eyes, and also after every 20 to 30 minutes interval, take a break, which is known as a stretch break. So if he takes a stretch break, he stretches out, he relaxes his muscles, and believe me, sitting is more injurious to the spine than standing. So it is better we set alarms which will help us take breaks, and we can actually stand for some time and allow our neck and spine to relax. Apart from that, we should limit the use of the screen time, especially we see people at long stretch on mobiles. So we should limit it to 6 to 8 hours max over a day, including both the laptop and the mobile. And preferably, a desktop is more useful than a laptop, because people tend to keep laptops on the lap, and they see the screen, and desktop usually the height is proper, so the people usually tend to get less pain if they see a desktop. Apart from that, we can actually, after those people who are sitting for long hours in the office, we can ask them to move about at least after half an hour or 1 hour. Move about for 5 to 10 minutes. There's usually a small stretch break which involves just standing for some time and just stretching. The second is a longer stretch break where we move about for some time and relax our muscles. If we don't inculcate these conservative habits, uh, we will require frequent consultations, and we will also require prolonged treatment.
Thank you. Thank you, Dr. Nayak, for a very simplified way of telling about ergonomics and preventive measures. So Navita, patient has come. We are told about prevention, patient education. What is the first line of management you will take in a patient with a mechanical muscle type of pain versus patient with a radicular pain?
So yeah, so it depends on also whether it's the muscle or the nerve or a radicular pain. We have to see the chronicity, whether it's an acute pain or we are dealing with a chronic pain. So that management depends on that. So if it is an acute spasm, if you are dealing with an acute muscle spasm or an acute radicular pain, then we have to advise a bed rest, conservative management, and this is very important that bed rest in radicular pains not more than 4 to 5 days is very important. Otherwise, patients come to me and they are on rest for months together. So that reduces or that weakens the muscle. So that we have to be very careful in advising the bed rest. So first and foremost is in acute pain is bed rest along with the analgesics. And the judicious uses of analgesics, because we have to know what is the comorbidities. Accordingly, we have to choose our analgesics. Now we have already discussed that what is the pain generator. The pain generator is muscle, nerve, or ligament, bone, or the joint. Depending on that, the choice of our analgesia is based. So if it is a muscle, then the muscle relaxant along with an anti-inflammatory will help. If there's a nerve, then we can add an adjuvant, which is the most commonly used are the gabapentin and the pregabalin, and also duloxetine. If we are dealing with now that is how we go about. Now after the bed rest, now the patient has come out of that and we are dealing in subacute or a chronic pain. So if it's a chronic pain, patient comes to me, then there is a WHO step ladder pattern in which we have to go stepwise approach on the how much is the pain, whether it's a mild, moderate, or severe pain. So if it's severe pain, then we start with a weaker opioids like tramadol and tapentadol. And again, if muscle is involved and a muscle relaxant, we can give a cocktail of if a neurogenic pain, then we can add an adjuvant, what we have spoken about. And if it is a mild pain, we can start off with non-steroidal anti-inflammatory drugs along with acetaminophen, muscle relaxant, and in between we can switch mild to moderate and then reassess. And this is how we now when the acute phase has passed, we have to heat and cold is very important when the acute spasm is there. So we can go for a hot pack and followed by liniments. Again, that gives temporary relief, but they do help a lot. And then in the chronic phase, along with the medication, we can start physical therapy, because as we have already told them, whenever the patient comes to me, we say that the pain has to go and it should not come back. So if it is the ergonomical or it's the occupational hazard which is causing the pain, so we start this with the physical therapy. We have to deal with relaxing the muscle. If there are myofascial band, we have to open up the bands. If there's a radicular pain, we have to give them the braces or in the neck or the back when they are walking, and also the right kind of physical therapy, starting from isometrics and then moving on to the strengthening exercises. So this is how we should maintain, or we should approach to a patient with acute or chronic in a stepwise manner, in a conservative for 3 to 4 weeks.
Thank you, Navita. So we have a diagnosis, we have the investigations, we have the prevention, we have first line of management. Now patient has come for a follow-up, he has inadequate pain relief. Now 4 weeks have gone, it's a radicular pain, mild reduction symptom 30%, still has back pain. So one way is to go for surgery, one way is to go for something called as interventional pain management. So last first, Dr. Sakla, what are the red flags we will look for in these patients?
Right. First of all, we'll see that our diagnosis is correct and we are not missing out anything. So we'll review all the investigations and the clinical findings that we see and compare those findings with the previous examination and see we are dealing with the same problem or there is something else that has not been diagnosed so far. And if it is a suspected case, we can order another investigations, something like CT scan or dynamic x-rays or some sort of dynamic studies in the CT scan, EMGs and nerve conductions, etc. The idea is to find out whether the patient's clinical symptoms are really correlating very well with the radiological findings. And if this is happening, then the next thing to see and review the conservative treatment, whether the conservative treatment has been given completely or there's something else which can be tried in order to relieve the patient's symptoms. Surgery will be indicated only if the clinical symptoms are progressive. They are correlating very well with the radiological investigation that you have ordered so far. And the conservative treatment have been tried fully and for the complete duration. And you are quite right that now the conservative management has failed. So in these circumstances, you can consider surgery on these patients.
So in this era of intervention-based medicine, there's something which is in between conservative management and surgery, and that's called as interventional pain management. So Navita, what is interventional pain management and what it has role in neck and back pain management?
Yeah, so whenever we say a patient is not responding or the conservative management has failed, and whenever it has been seen that we say, okay, you have to go undergo a surgery or undergo a knife, the patient, you know how in our country, they always, the neighbors are the doctors, the family is full of doctors because they all have their own ideas. So they'll say, okay, no, somewhere in my relative they had a surgery and there was some side effect, and then surgery at the spine is again, there is a lot of misery which a patient has to go through. What will happen, how will it go? So then that is where the role of interventional pain management it comes into. Basically these interventional pain management these are the minimally invasive procedures, or we say injections, which involve reducing the pain stimulus, or it may be temporary or it may be permanent, where we block the nerves or we inject, we identify, because we have already identified what is the cause, the pain generator, and we use image guided techniques. It can be ultrasound, it can be CT, it can be fluoro guided, and even MRI guided. So when we know that there's a radicular pain and the L4 nerve root is getting involved, then we can go ahead and do an L4, L5 transforaminal epidural steroid. So then the need of oral steroid is not there. We know that there is a disc, slip disc is causing the compression on the nerve root. We identify, we take the patient in OT, and it's just like a daycare procedure. We identify the nerve root and then we inject around the nerve so that we can wait till the patient, the surgery can be negated or can wait, we can buy some time. So that's here for the nerves. But even in the muscle, when we are talking of the occupational hazards, where we do get myofascial pain and trigger points, we can identify these trigger points not only clinically by the palpation method, but we can identify with ultrasound, and inject into the trigger points, finding out all those trigger points and then injecting into those points, followed by physical therapy, and then that can continue. If there is a peripheral nerve which is causing the pain, because again, it can be a joint, so we can identify the joint under guidance, maybe ultrasound or fluoro, and then do an intra-articular procedure. And if the intra-articular doesn't help, maybe he comes back after a month or so, or 2 months, then we can ablate the nerve which is supplying the joint. So this is how we can help. Even intradiscal procedures can be done to reduce in a herniated disc. So we can inject into the disc, into the joint into the muscle and around the nerve, and thus we can help the patient before they go. If there are no red flags, important thing is if there are red flags, there's no role of interventional pain management. Then the patient has to go for surgery, whether he wants it or not. But yes, this can help, and this bridges the gap between the pharmacological and the surgical management.
Very well said. So we know now some patients who cannot undergo surgery because of multiple comorbidities, or they are not ready for a surgery right now, do something called interventional pain management. Now, some patients have red flags, or those who have failed conservative management, failed interventional pain management, have to go for definitive procedure. So what common procedure will you do, Dr. Sakla, in these patients? What is the role of what is also the role of minimally invasive procedures now?
Right.
These are of
Okay, so nowadays our preference is to use the minimally invasive procedure, and now we have got a whole lot of surgical procedures which can be tried as a minimally invasive method to treat some of these lesions. So that is mainly the endoscopic surgery, the keyhole surgery, and the motion preservation surgery by using various implants, and the instrumentation which is done percutaneously without opening and disturbing the integrity of the vertebral column. All these things can be done in even the awake patients who do not want general anesthesia. So transforaminal discectomy is one of those very common methods that we have been using in the recent times. These minimally invasive procedures we tried as a #1 procedure, even in the young persons. Only those patients who have, large segment of degenerative disease, and where you need that is a large segment of the vertebral column needs to be stabilized. That is where we go for the open surgery. But most of the surgeries are nowadays minimally invasive, and the success rate is very satisfactory.
Thank you, Professor Sakla. Ellen, what is the current scenario of neck and back pain management in UK?
So that would be the physical medicine team that with physiotherapist and occupational therapist looking after them. I think they have a good setup, but that depends on where you are living. I think that applies to everywhere in the world, that if you are living in a big city, there are lots of opportunities. If you are living on the countryside, that there may be a long way to hospital and few specialists available. So yeah, I'm not working closely with the team working on these topics. So yeah.
Yeah. Thank you. Professor Mendiratha, so just to conclude about neck and back pain management, how will you summarize it, sir?
Thank you so much. So I express my opinion. I heard other experts, Dr. Naik, Dr. Sankla, Dr. Navita Vyas, and now Professor Allen. We have to carefully, again, by history, good clinical examination, and wide investigation. Not that we get all on the earth. We should not be investigative doctor, but we should be a clinical clinician, supplemented by investigations. And suppose postural or this, what I say, like most of the patients who come these days with pain, young patients, are technology experts or IT experts. That's doubt. Now, elder or those, if it's not traumatic, then we have to find out. Usually it is this. And radiating pain, you have to carefully ask. Is it in a radicular pattern or it is a spinothalamic pattern? If it is whole limb and it is deep-seated, then chances are there is a myelopathy coming up. And in that situation, we have to intervene without delay. And we should take, I always say, as you look for ergonomic chair, similarly, you should look for ergonomic pillows. Mr. Durgesh Pathak has asked the question also. Similarly, we must handle the underlying cause. When red flags are there, suppose there is no neck stiffness, or there is marked neck stiffness in, say, young patient, and no stiffness in very young children and elderly, you must suspect meningitis and carefully look into that. That's one of the very important red flags which we often see. If it is after trauma and there is some brain dysfunction coming up, brain dysfunction in the form of, say, visual hallucinations or some TIA, you must suspect cervical dissection of the carotid or vertebral and handle accordingly. I think with this I will sum up, and most of the causes again of neck pain and backache is usually positional or occupational hazard, which can be handled easily. And let us have break from continuous screen time. Abhishek has asked us to sit in front of screen for more than 1.5 hours. We are likely to have some neck or back pain. Thank you so much, Abhishek.
Yes, sir.
Thank you.
So we know there are, so just to take home message for the pain is primarily, there are two types of pain, a muscle or a degenerative pain, which primarily requires physical therapy to stretch your muscles, ergonomics, preventive measures, some medications not helping, give a local myofascial block to reduce those trigger points. If it's a radicular pain, rest, some role of bracing with medications, adjuvant medications, physical therapy. Step 1 doesn't help, can't go for surgery, multiple comorbidities, plan for interventional pain management, get a block. If you get relief, continue with therapy. If again inadequate relief, plan for a surgery. That finishes our first part of the neck and back pain management. Let's turn to autonomic dysfunction. And we talk about bladder problems, bowel problems, and sexual dysfunction. So my first question is to Dr. Nayak. Dr. Sakla, please. What are the common neurogenic bladder problems you see in your practice? And what are the common symptoms people have primarily when they come to you as a neurosurgeon?
Yeah, you get all sorts of symptoms, including due to the spinal problems, including just hesitancy in passing urine, to more severe is the partial retention, full retention, and then incontinence of urine, which we see mostly in the patients who suffer from the spinal disorders. People who have chronic degenerative disorder, in those patients, the urinary functions are so subtle that at times it becomes very difficult to really identify or recognize that the patient is suffering from some sort of chronic being not able to pass urine perfectly, and it's a chronically going on retention of urine in these patients. As opposed to that, in the acute cases, for example, spinal fractures or spinal surgery and all that, these cases you get the acute symptoms, acute retention of urine. Another confusing area of identifying the problem is in elderly patients, where prostate plays a very major role. Some of them have already been diagnosed to have some prostatic problem, and some of them come without the knowledge of the prostatic problem. And when they go into urinary problems, then it becomes very difficult to identify what exactly is happening, and you need to take the help of the urologist to help you salvage this problem.
Dr. Sakla spoke about the common acute trauma and the spinal problems. Dr. Mendiratha, what are the other cerebral reasons, especially in elderly people, which can cause bladder involvement?
Only elderly people?
Even young.
Okay, thank you. Invariably, the bladder dysfunction is organic, sometimes can be psychogenic. Most of the common causes are non-traumatic, but can be traumatic as well, as spinal cord injury has been mentioned. Now, this bladder dysfunction, I will not go into whether it is retention or retention overflow, incontinence or spastic bladder or autonomic, but this can be peripheral in the form of cauda-equina syndrome, which is usually with asymmetry. Now, this can be spinal cord lesion, In intramedullary, it will very early come. And if it is unilateral dorsal pain, and then there is a level, and then bladder comes, which can happen in extradural or intradural pathology. The other pathology, which can be central, can be in the brain. Brain, the urinary incontinence can happen number of conditions. We know normal pressure hydrocephalus, vascular Parkinsonism, Binswanger disease, and also in neurodegenerative conditions, which I think Professor Allen will also like, are like multisystem atrophy. Say multisystem atrophy, whether cerebellar type or Parkinson type, will have autonomic dysfunction associated. So whenever I get these patients, I ask the staff to do blood pressure lying down and standing. Because invariably now, earlier we used to do in 3 positions, lying, sitting, and standing, but even these 2 positions are good enough. And similarly, side we can do autonomic function in these patients, like cold immersion test, arithmetic calculation, simple tests like tachycardia, head up tilt test, heart test, which we say, or 24 hours automated blood pressure monitoring or whole monitoring. So these will decide about the causes. So very important. Bladder dysfunction alone, it may be difficult to discern until unless we clearly know it is lower motor neuron or upper motor neuron, organic or psychogenic. But associated neighborhood area signs. Suppose you find one ankle jerk absent and patient has bladder dysfunction, which has come with back pain, likely to be caudicoid. If it is transverse level is there, it's spinal cord. If we go up, then if it is a clinical triad, then NPH. And if it is neurodegenerative condition, painless, progressive, with falls, frequent falls, likely to be MSA. So these are the common causes, Abhishek. There are so many other things to discuss, but time will not permit. Thank you.
So now we know there are brain causes for bladder dysfunction, spinal cord causes, or a peripheral nerve. 3 basic can be right. So Dr. Nayak, how do you evaluate these bladder dysfunction? Patient has come to you, we've done a history, we know what's wrong. Now, what investigation will you do to plan the further treatment?
So, excuse me. So, as basically Sir has pointed out, we look for 3 types of bladder defects in a neurologic patient. Basically, those are cerebral, which is actually above the pontine micturition center. From the pontine micturition center to the sacral center, those are the second type of lesions, which are basically the supraspinal lesions, and we look for those below. So the presentation of these 3 types are different. Usually we get an atonic bladder or an element bladder, and for that the basic investigations consists of an ultrasound KUB. We also look at the functions of the sphincter, the external sphincter. So for that we can go for a urodynamic. For any lower urinary tract dysfunction, we usually do a routine simple urine routine microscopy culture. All these investigations are done for the peripheral lesions. Apart from that, if we have a spinal lesion, especially we have an overactive bladder or an overactive detrusor, usually we go for avoiding cystourethrogram. We also look at the typical, we look for these renal cortical dysfunction, especially using isotope studies. And a uroflowmetry is very vital. Especially we monitor the EMG and we do a cystoscopy and see the bladder flow dynamics. So these are the basic investigations for cortical causes, especially if it is a case of MS or it is some cortical injury, traumatic brain injury. So for those cases, we usually have to go for ultrasound KUB, and we have to look at the flow dynamics.
Thank you, Professor Nayak. So, Professor Hagen, we have now three basic categories. The most commonly seen in practice is people with spinal involvement in rehab primarily, those who have a spinal cord injury or an MS. So how do you manage these patients?
So I previously managed quite a number of of MS patients, but then I moved to spinal cord injuries. And what we see, especially in spinal cord injuries, is that when people see them, they think what they want to do is to move, to walk again. But actually being able to manage the bladder and bowel and sexual function is a much more important topic for the patients themselves, because having in urinary and bladder and bowel incontinence is really embarrassing, and it's really struggling and affects their quality of life, and it affects how they interact with other people. We have for urodynamic, doing a proper urodynamic study and then thinking, how can they manage? Do they need to use intermittent catheterizing? Do they need to have permanent catheter? Do they need to have suprapubic catheter? Especially for women, having a suprapubic catheter make life quite much easier, because they don't need to think about where can I get to a toilet where I can open my bladder. So it's thinking what can help them to achieve a good life, a high quality of life.
So one question comes up. Initially, when we were studying, we were told that do intermittent catheterization is the best way forward in spinal cord injury. But now a lot of trend has come towards catheter-free status and try pharmacological measures. What's the catheterization? What's your experience in that?
I think that if it's an incomplete and they have some sensation, they might be able to do without a catheter and without any aids. But many patients need aids, and aids are there to help them. So I think we need to it's a discussion with each patient. How do they want, if they are elderly, will they be able to get to the toilet in time? If they are very active, do they need to be able to move around without being concerned about how can I, where can I open my bladder? So it's a very personal, up to their way of living. And of course, if we take the world into consideration, clearly in many places, especially in India, there isn't many options available. You can't have sophisticated procedures if you are not able to be followed up in the hospital, if the hospital is far away and it takes you days to get there. And we do see that also in Europe, that some people are living very far away from hospitals and specialists, and then you need to compromise to find a solution they can live with, which is safe for them. We don't want them to get into have infections, urinary infection, renal infections. So that's a really big thing too. And then you need to think prevention by making sure they are drinking enough to secure, and maybe antibiotics to secure, avoid bladder infection.
Yeah, there are two ways to look into it, as we have discussed. One is, do we need a continuous catheterization? People are still bedbound, can't move around, need either an indwelling catheter, a perurethral or suprapubic. Second, those who have some mobility, can have enough hand function, go intermittent catheterization. Third, who are walking enough, mobile in the community, don't want a catheter, they can go for pharmacological measures. If they can pass enough, have a balanced bladder with insignificant residual urine, they can be able to manage in the community with a low PVR with the medications. Now, there are some patients who especially are elderly, Dr. Nayak, those who have MSA or Parkinson's, have a complicated enlarged prostate with diabetes. So they have all 2-3 components of neurogenic bladder. What do you do with those type of patients?
So usually those patients who have both an upper and a lower type of, means a central nervous system plus a peripheral nervous system involvement. Usually the management is very difficult, especially when the patient is unable to take care of himself. And what is needed is that the catheter care has to be proper. Apart from that, management has to be done conservatively for the symptoms of the patient. Especially we go for drugs, we go for antispasmodics, anticholinergics, and alpha blockers are useful drugs, especially if there is an obstruction to the external sphincter. And apart from that, we also ask the patient for a hygienic bladder care, either if, as you have reiterated, there's intermittent catheterization, or if he's bedbound, regular catheter change and care of the catheter. Apart from that, we have to look at other comorbid things like a bed sore, which can lead to recurrent infection, and especially the anal canal. There are associated bowel dysfunctions, so that has to be taken care of. Bed posturing has to be taken care of, and it is more important that hydration has to be maintained in these patients because they are unable to tell about hydration.
Thank you, Dr. Nayak. Last question on bladder management, Professor Hagen. What's your opinion regarding role of botulinum toxin in detus overactivity? And how frequently do you recommend any surgical cystoplasties in these patients?
So Botox in the bladder has, many of my patients has very good effect of that. So usually they need a refill every 3 to 6 months. And yeah, that is definitely something I would recommend if we found them suitable for it. Cystoplasty, I can't remember the last patient I had who got that one. It may be that that's not so much used in UK. Yeah.
So if you can follow adequate conservative management, especially for bladder care with proper investigations, the whole concept is called as balanced bladder. If you can pass enough urine, so what remains in the bladder after passing is less than 60-70 ml, called as insignificant PVR, either with help of medication or catheterization, you can have a healthy life and you might not require interventional surgeries. If you need some medication to relax the bladder, if it is causing involuntary contractions, you might need some medication in elderly people. Dr. Nayak told about alpha blockers to relax the sphincter. And some patients who have persistent stiffness in the bladder might require a botulinum toxin injection. The role of surgery is not too much right now in urinary bladders. Thank you. Go to the third point, which is immunogenic bowel dysfunction. So, sorry, Dr. Nayak, what are the most common symptoms you see in patients who present to you with the bowel problems?
So basically, what we see is causes, central causes like the traumatic brain injury patients. We see also spinal cord injury patients. Usually they present with symptoms of constipation, and they also present occasionally with intermittent fecal incontinence. 95% of the patients of spinal cord injury present with constipation, while if you see traumatic brain injury patients, at least 60 to 70% present with constipation. Apart from that, there are other medical causes like stroke, Parkinson's, MS, and MSA, as Sir has already reiterated, who can have bowel dysfunction. In the tune of 30 to 50% of patients have constipation, and constipation is very acute in Parkinson's, especially 50 to 60% of the patients, unless otherwise asked, they report constipation. Apart from that, bowel dysfunction is also common in pediatric age group, especially there's functional constipation, and there is also functional fecal incontinence, known as FNRFI. So these are some of the common conditions, dementia also included, where we find either constipation with or without intermittent fecal incontinence, and sometimes we find gross fecal incontinence also, especially in spina bifida.
So we have two types of problems. We know one is inability to evacuate. Second is incontinence. So Professor Hagen, how will you evaluate these patients with bowel dysfunction?
So we usually they have been through a regular, had a colonoscopy and gastroscopy to see, but very often it's part of the autonomic dysfunction that it affects. The gut is a massive neural organ, so you get autonomic dysfunction with reduced motility. And for many of the spinal cord patients, they also get because they are so constipated, they get diarrhea, overflow diarrhea. I've recently seen a couple of my patients with spinal cord injury having colostomy, and that actually made a huge difference to their life, because when they are constipated, that push up their blood pressure, and then they open their bowels and they get a severe blood pressure drop. So they have this cycle of high blood pressure, low blood pressure, triggering autonomic dysreflexia, and life is just not at a very good quality. I had one patient who had a colonostomy earlier this year, and prior to that, he couldn't sit up while eating because he just fainted. And the day after his procedure, he was sitting up and doing fine. And it was just nearly a miracle to see how much that procedure actually changed his quality of life. And of course, if you are concerned, if you're walking and you're concerned that you will be incontinent of your bowels, that it's so, people are so ashamed, they are feeling so poorly. Yeah, so doing a proper examination and then thinking of if drugs are not sufficient, of course you are using the Senna, you're using both medical and non-medical remedies like dates and things that can help for your digestion. But if that's not working, sometimes you need the really big stuff like colonostomy.
Thank you. So Dr. Navita, you have long experience in managing both neurogenic patients as well as patients who are on opioids causing constipation. So how do you manage such patient with neurogenic bowel dysfunction?
Yeah, so we can start with looking at what exactly, whether we are dealing with UMN or an LMN lesion. So we can start with behavioral treatments to begin with, like dietary modification, lifestyle modification, fluid consumption, and then diet rich in fibers. And we can also prescribe soluble fibers like Isapola or in this thing in their diet. And second thing is when they are not able, they are constipated, they are not able to evacuate. So then there is something called as reflex. So digital rectal stimulation, in which with a gloved lubricated finger, you tell the patient that you can do a digital, you can put your digit into the rectus and then do a circular motion in the anal canal, and that will help in stimulating, or it will be the rectocolic reflex will be stimulated, and then the evacuation can happen. Then there are some studies which suggest that abdominal massages also help in evacuation. So we can teach them those abdominal massages. And then there's a dyssynergia, and then when there is a pelvic floor dysfunction, So in that, the biofeedback or using the help of the physical therapist, we tell them to stimulate the pelvic floor muscle, that is the biofeedback, or EMG biofeedback can help in minimal to moderate disability. Then we can also add some medical pharmacological management in adding prokinetics, and also the use of laxatives like bulk forming agents can be used, or osmotic agents like we use a lot of lactulose. It can be added in the diet of the patient. And also like prokinetic drugs like can be added, which is like prucalopride, commonly known as Pluvicto 2 mg, can be given, and it helps in again in gastric motility. Then neostigmine and all these, they are also very helpful in improving the gastric motility. Then the other things is when there is a evacuation, the difficulty in evacuation, and there's a fecal impaction, again manual evacuation, and the suppositories and the enemas, they can be used. And when we were talking about incontinence, then we can use anal caps for soiling, for the patient feel very embarrassed that they are having these fecal incontinence. They keep on passing motion and they don't know. So then the anal cap for some timed, as we have timed bladder program, we can do a timed bowel program for these patients. And then moving on, it's like an algorithm. So it's like if things are not working, then we can go for neuromodulation, and lastly the surgical techniques like colostomies, or if there's a dyssynergia in the sphincter, then we can go for sphincterotomies. So I think so in nutshell, we can go in a stepwise manner from behavioral modification to surgical management, depending on where our patient stands.
Just to add, we were told that bowel is a
bowel program. Yeah,
bowel
we used to do a bowel. Yeah,
bowel is a teacher of reflex. Do what you used to do earlier. Also, many people use something called as gastrocolic reflex. So when you eat food, and then when you eat food, it goes to your stomach, I think it's to your colon. So post breakfast, very common time people with spinal cord actually pass motion. Sakla, please, would you add anything?
This just to add, the bowel bladder problems in children, very small children with spinal dysraphism, they really are very difficult to treat and really challenging. How do you deal with them? Do you deal with them differently than you have to do in the adults, or is there any other method to treat that? Dr.
Hagen?
Professor Hagen, if anybody can really comment on that, please.
I'm sorry, I have only been dealing with adult patients, so I don't, I have had a few spinal cord injured children, but not regularly seeing the spina bifida children. They have been seen elsewhere. Yeah. I was just wondering, are you using Peristeen? The setup with Peristeen, where you empty your bowels?
No.
No. Okay. Yeah.
Pastor Mendiratha, you want to comment upon children problems, pediatric issues, and bladder bowel management?
Abhishek, I can put a disclaimer here. I'm an adult neurologist.
Okay.
But I think most of these will have lower motor neuron type of bladder dysfunction. That's like cauda equina, and because of tethered cord or pulling on the roots. And the management will differ much from the lower motor neuron type of bladder.
Yeah.
And only thing we have to avoid, say, retention happening, stagnation happening, and then infection happening. So those things we should, and in children, they may not be nothing to tell. So duty of the treating doctor and the parents should be taught that how to empty the bladder. As I say, if there is a stagnation of urine, it's like a water in the pond. and that will invite algae. So same way I see that will invite bacteria and infection that may be more difficult to treat than bladder dysfunction.
Yeah.
Thank you.
Just to add, continue that,
Can-
especially children with spina bifida primarily have a element type of bowel, and they can present with both constipation as well as fecal incontinence. And the bladder is primarily element type. You can teach CIC to the parents. A child, when he grows up, can do CIC himself. So they can do CIC well. They can manage their bladder quite well in long term.
Regarding the, can I add to this?
Yeah,
Because
please.
they can do the CIC for the bladder and for the bowel. I think so the management remains the same in adult and pediatric, because we have had seen a lot of, during our residency, and also right now we have had seen quite a few pediatric patients. The only thing is that using laxatives in the pediatric, we have to restrict ourselves, and we can teach the parents regarding the rectocolic or the gastrocolic reflex. So that helps a lot, and abdominal massages also helps a lot. And there is something called as as we do a toilet training, when the child grows, we can develop a bowel program for these patients, like in adults, that okay, you do a dietary modification, lifestyle modification, and then make them sit on the commode chair, and just put a glycerin suppository, which will not harm. It will just start the rectocolic reflex, and then they will, in some due course of time, they will learn to evacuate the bladder. That is a reflex evacuation of the bladder. I think bowel. Sorry, I think so. This is how we used to manage. We manage.
Yeah.
Thank you.
Lightweight. Thank you. We come to the last part. We have 10 more minutes. Professor Meshram is already there. The last part is on sexual dysfunction. So, Professor Mendiratha, what are the common complaints of neurogenic sexual dysfunction, both in men and women, you see in your clinical practice?
Thank you so much. I may have seen cases who have biological conditions, but by and large, first I will say this is often underdiagnosed entity. It's often under asked by the treating physician and underreported by the patient because of hesitation, and invariably in a country like India, there is a family which accompanies the patient. So invariably they will not like to discuss. So this one very important point is that we must carefully inquire, especially winning the confidence of the patient, not directly go to what are the sexual dysfunctions. We are not sexual or those experts. So first of all, we must win the confidence of the patient, discuss with them, and then ask, even there, would you like to tell me something separately? Then request the family to wait outside and then discuss. This has recently happened with me in one of the patients. He sent his son out that I want to talk to Dr. Saab something. He was just 57. So the other thing which is common are, we know, the main is desire, orgasm, that's erection, and ejaculation. So all these symptoms patient can complain about the neurogenic sexual dysfunction. Now again, I will say the one way is that when patient comes isolated with this, which is very unlikely in neurological condition, unless it is psychogenic. Too much of stress can cause this. But otherwise, there will be some accompaniments. Now, these accompaniments can be like diabetes. Diabetes is a very common condition. We are often ignored to ask this. And they may have silent autonomic neuropathy. And usually, diabetes don't manifest these neuropathy on very first day. On an average, it takes 5 years to manifest as peripheral neuropathy or autonomic neuropathy. Autonomic neuropathy may stay silent, but we have to assess bedside and in the lab, autonomic lab, what are the dysfunctions. And then if there are related to sexual dysfunction, then there are specific tests we know which can be like penile stimulation, evoke potential recording, and other things. So in my opinion, the first foremost message is that we should be aware to ask this question. Now, if the person has got, say, Parkinsonism, that Parkinsonism may be like multi-system atrophy. And autonomy comes with ataxia, staggering gait, I'm walking slow. But if we ask autonomic functions, one is testing, what I said, sitting, standing, blood pressure, and heart test or pulse rate or ECG long lead. But we must inquire about this unless we are doing a research project or thesis. It should be a routine practice, number one. Number two, this should also be, patient should also be taken into confidence to tell these things. And thereafter comes the finding out the cause. Again, I will say, Professor Allen can correct me, in isolation, neurogenic dysfunction is very unlikely unless something is sitting in the cauda equina area. So it's very, very unlikely, which is silent and you find on MRI something. That's different. Then there are various diagnostic tests which can be done. And I think, again, I will lay emphasis, look for the neighborhood signs, look for the neighborhood symptoms, accompaniments, and then accordingly investigate. Thank you.
With this, I think we have a very elaborate discussion on all these 4 topics today. I hand over dais back to Professor Chandrasekhar Mishra, please. We have finished in time.
Thank you, Abhishek. Dr. Nirmal Surya would like to make some comments.
I think this was an excellent program and a wonderful question and answer. I'm absolutely sure that those who were around, they must have benefited enormously from the expertise comment as well as question and answer. I personally thank all of them for being there. And tomorrow, the last day of Brain Week, and Chandrasekhar will update you on the tomorrow's program, which is another interesting program. And Chandrasekhar, tomorrow we can have 10 minutes for the Neurogama team to sing that particular neurology song to sum the end of the Brain Week. That will be a very...
Okay, sure. Yeah, we can extend the program tomorrow by about 15 minutes, the last session.
And we can have also the if Professor Wolfgang can join, or some of them, Steve Lewis, they can, we can update them about the whole thing and we can hear their comment.
Okay, sure. I will ask.
If possible.
So I think we had a great session, and thank you, Professor Allen, for being with us and enlightening us. And I would like to thank Dr. Abhishek for wonderfully conducting this session, planning the session. And it's all credit to Abhishek. We keep troubling him every now and then for public Yoshugana activities. Thank you, Abhishek. Thank you, Professor Manmohan Mendiratta, Dr. Suresh Shankla, Soumya Darshan Nayak, and Navita Das. Tomorrow, we have a session on loss of memory, and it will be moderated by Dr. Atanu Vishwas. We have the international faculty, Professor Riyad Goder from Tunisia, and Dr. Agustina Charvefeli from Ghana. And we will have national faculty, Dr. Amitabh Ghosh, Fain Arshad, Dr. Meera Chandra, Dr. Sujata Das, and Dr. Mrs. Vidya Shenoy. So another interesting session, and we'll have a brief closing ceremony tomorrow. So please join tomorrow with the same link, same time, 6:30 p.m. See you tomorrow. Thank you very much for joining this very important session. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, everybody. Thank you. Thanks for joining. Bye-bye.
Thank you.
Thank you, Ellen. Thank you.